Hello, Namaste, good day everyone. My name is Dr. Varalakshmi Divakarla and today we'll try to learn a little bit about conflict management in the ICU. Now coming to the scope of conflict in the ICU, if you remember, this picture is from my previous videos if you have seen them. So it is as much as the scope for communication. So there could be conflict amongst team members of the ICU team, amongst nurses and physicians, among doctors and the other staff, other multidisciplinary doctors, between family members, between patients and family members, patients and doctors, patients and nurses. So the scope for conflict is as endless as is the scope for communication. So why do we need to even learn about conflict management in the ICU? Is it such a common occurrence, or is it something that is common only in our scenario? Several studies have shown, like this one by Elie Azule has shown that actually doctors and physicians working in the ICU were asked to respond, and in their survey they found that almost 71% of the respondents had perceived conflict in their in their work area in 1 week prior to the time that the survey was taken, and 53% of these were perceived as severe conflicts. Now most of these were nurse physician conflicts, also intra-nurse conflicts or conflicts between ICU team and family or surrogates. So it is a pretty common occurrence and we need to address it. Now if we have to understand conflict, it's important for us to remember the stages of conflict. Alright, so there is, like in always in most of the situations, there would be a latent phase when there is conflict, but it is still under the wraps, nothing is really visible outside, but there is a conflict. Then there is a sudden surge where it becomes very obvious, that is conflict emergence. Then it becomes escalated, it goes to its peaks where it stays there for some time. Then there is a stalemate, it stays there up where there is a very high intensity, high level of conflict. Then subsequently, depending on the stalemate will take will stay there how much ever time you give it or you take to resolve it, and then it will gradually de-escalate with all the negotiations and all the resolution management strategies that you adopt, and finally it should settle down and they should come to there'll come a stage when there is a post-conflict sort of peace building kind of a stage. So these are the stages of conflict. And again, lot of theories have been made on this, and one interesting one is the Thomas Kilmann conflict mode instrument. Now this is one instrument which will make us understand how different people respond to conflicts and why they do so. So in this, what these Thomas and Kilmann, what they have done is, in the early 90s, they plotted two things. One is concern for others' agenda and concerns for own agenda. They have plotted these against each other, and they have so one end is the low concern for others' agenda, the other end is high on the x-axis, and on the y-axis we have low concern for one's own agenda going to the high concern for one's own agenda. So in this, if you see, when do people adopt avoiding conflict? This is usually done when the concern for others' agenda is low and concern for one's own agenda is also low. This may be when the issues are trivial, when they don't really matter, or there's nothing much that either party can do anything about it. This is one extreme. Now when the concern for one's own agenda is very high, but for the others is extremely low, then you have a competing kind of a response to conflict. Then the other end, when the concern for the others' agenda is very, very high, that's when your approach to conflict is more of an accommodating type. When the concern for yourself is high and also for the others is high, that is when you start collaborating, and that's what you basically look for in an ideal scenario, in an ideal team. Somewhere in between all this is compromise, where you draw a middle ground between your own agenda and the other person or the other team's agenda. So that's how this sort of instrument is useful for us to determine where a person stands and why in a situation of conflict. Next, coming to the origin of conflict. Now we all understand that conflict means there are two opposing actions, beliefs or interests. When does this thing start? Usually it starts when we start discussing goals of care in our critical care scenario, or when there is uncomfortable information around, some kind of error, some kind of judgmental error, medication error or decision error that has happened, or when you are dealing with controversial therapies. These are sort of the ingredients. In addition to that, when there is a discordant view among team members or between nurses, physicians, between family and patient and doctors, whatever it is. Second, when the values are different, values are disparate. Third, when there is a misunderstanding of prognosis. It could be anybody. The nurse could misunderstand it, the team members could misunderstand it, the other sort of healthcare teams can misunderstand it. It can happen anytime. Then when there is ineffective communication and the prognostic expectation is misaligned, we are not on the same line as far as the prognostic expectation goes. That is the physicians, the treating party and the patient sort of attendants or family. And in a charged up emotional environment, which is very, very common in the ICU. Then there are several other sort of ways of looking at it. We can look at conflict as maybe an organizational conflict, where there can be situations where people are forced to work with deficient resources, structures are not properly in place, processes are not clearly defined, and management is very, very suboptimal. So in this kind of a situation, there is a lot of conflict. The other one is a procedural sort of problem. Like it could be either miscommunication between team members or among the team itself, or with other teams that can cause procedural conflicts. Then there could be contextual conflicts. There could be differences of opinion as far as which concern the society, which involve some kind of your political sort of inclination, or there could be problems with legal understanding of situations or cultural differences among team members. The last one is personal conflicts. These are usually the worst ones. These are what create like lot of problems, and these could be because you dislike the other team person, or you have aversion towards that person, or you don't trust the team, or your individual goals take predominance while you are in a team, and individual achievements are become much more important than team achievements. And when monetary sort of problems are added, if your achievements, or if there are monetary discrepancies, or if it matters to your research, or if it matters to your education. So these are all problems where personal issues become a cause of conflict. So coming to these specific problems in the ICU, most of our discussion will be about impaired surrogate decision making. We understand that surrogates are put into a situation where they have to take decisions on behalf of the sick person, of the patient. Now, even if it is a chronic situation, if it is a chronic illness, say a malignancy, or a sort of an acute exacerbation COPD, or a cerebrovascular accident, or a very sort of severe sort of respiratory illness, or a neurological illness, what happens is, most of the times no advanced planning has been made by the family or by the patient. No directives have been given. So this causes lot of the confusion to the surrogate. They don't know what to do. This is a chronic situation. Coming to acute situations, so the patient comes suddenly to the ICU. let's say something like a road traffic accident or a bad stroke which happens suddenly, then there is too much of stress that the surrogate is under. So because of this acute stress, they are usually not in a position to understand what you're saying. So the cognition is poor, information processing is deranged, then there is lot of biases that come into picture, and added to this, if there is ineffective communication, then the decision becomes impaired. The kind of decision making becomes impaired. Now, in addition to this, there could be family discord. They don't understand goals, they don't understand what they want to look at, they don't know their own expectations, or when they get conflicting information, different kinds of information from different healthcare personnel, then all these will contribute. Then when there is interpersonal, interdisciplinary disagreement, the surgeon says one thing, the intensivist opines the other way around. So, or when there is clinical uncertainty, prognostication is not very clear, or we don't have tools enough to give a clear prognosis, or when there is distorted dynamics because of communication failure. So there is finally a loss of trust in clinicians, and there is loss of trust by the family towards the healthcare system. So all these will cause an impaired surrogate decision making. There are several biases in which play a role when patients or families make decisions in the ICU. One important one is the optimism bias. So what happens in the optimism bias is, how much ever sort of information you give, whatever kind of inputs you give, the listener or the family or the surrogate will always have an unrealistic expectation. They will think that it may be true, but it won't happen to my person, it won't happen to my family member. So there is a build-up of something called an optimism bias. So in addition to these biases, we also need to keep in our mind two concepts here. One is something called a moral position, and the other is called a moral aporia. What is a moral position? Now we all understand that for conflict to be there, there has to be some kind of a harm involved. Now this harm can be physical, it can be emotional, or it could simply be a perceived harm. There is no actual harm that has taken place or can take place, but the family perceives that a harm can happen. So this in mind, there are two things. One thing is a moral position, in the sense all of us have certain inbuilt positions on certain things in life. So we either, when we approach a particular issue, we think of it as right, wrong, very clearly. So in our mind it is very clear. These are what are called as bedrock values. But the problem with these bedrock values is, it is very difficult to share these values. It is very difficult for us to come out openly and talk about these values. They require a stable, trustworthy relationship. And in the ICU, we are talking about a timeline of like sometimes 5 minutes, 10 minutes, which is hardly enough time to build trust and to give them the confidence to share their innermost bedrock values with us. On the other hand, there is something called moral aporia. What is moral aporia? Moral aporia is a situation where the answer to a question may not be one right or wrong. There may be several right answers, or there could be bits of the answers which are actually true in parts, but when you combine them as a whole, they may not really make sense. Like, for example, if I talk to a family who, a very sick patient who has been coming to the ICU very frequently, and then they have been, we keep on prognosticating, we say no, it's very unlikely that this patient, and that patient you see has a very, very poor quality of life. So you tell them that, we are in this decision together, we are all going to make that decision together. But what if this person is the most important person? He's a youngish person who, who gets a pension, who on which the other family members depend, or some kind of a situation like that, where although we tell them that we are in this together, actually who are in this mess is the family alone. There are a lot of other implications, other issues that come into play during the decision making process. When you keep such a situation in mind, when you get into a situation like this, so it's very important for us to remember that there could be a moral aporia, and this is very important to identify, because this means that what you feel may not be, or what you may choose in a particular situation may not be what the family wants to choose, number one. And the options are usually beyond binary. It's not usually yes or no, wrong or right. It can go beyond that. And it is beyond ethical and non-ethical. Sometimes we have to go beyond this to come to a correct sort of a thought process and a decision making in a condition like this. So there's another way of looking at causes of conflict. One, there could be substantive causes. What is this? When there is a sudden change in a health situation of a patient, that's when the issues start, right? Or there is a change in health capacity, or there is something that has happened that has personally affected a patient or a family member or a surrogate. Now again, this, it depends on their previous experiences, what their experiences have been with an ICU patient in the past, what kind of decisions were made, what happened, what was the end process of those decisions. So these all will come to mind when we think of the substantive causes. The next is the process issues. Process issues when family says that there are discrepancies, when they feel that during handover or during decision making processes, the process has not been correct, has not been fluent, and you're hearing variable information, you're hearing different things from different people, or you see that care is discordant. Suppose they are seeing 3 patients, 1, 2, 3, similar illnesses, and they are saying that one particular patient is getting one kind of care, the other is getting another kind of care. And this may not be during their stay in the ICU or their family members' stay. It could be in the past, it could be what they've seen in the, starting from the OPD to the lab to the admission in the ER or to previous ICU admissions as well. All these can have a bearing. Number 2. The third is again relational. What does relational mean? Again, when there is opposing values. What you feel is right and what they feel is right or wrong may be opposing to each other, or when there is communication failure. So this is how we can summarize causes of conflict. Now the thing that helps us in understanding this is something called a conflict trigger matrix. Now it basically consists of both internal triggers and external triggers. It has something like family dynamics, medical system mistrust, cultural differences, caregiver disagreement, communication failure or information, empathy, health disparities, presence of chronic illnesses, and policies, how good or questionable are hospital or ICU policies. So this is one matrix which gives us a sort of it's a tool for us to understand where this conflict is coming from. It's very important for us to understand this. So like we were discussing, triggers can be either internal. What are these internal triggers? Prior experiences in the ICU, other family members, the same family member during the previous ICU visit, lack of trust, when there is a power imbalance, when the surrogate feels that he or she doesn't have enough power to make a statement, to have a stake, to have a real say in the decision making process. when there is a perception of bias or stigma, when the family feels that I am being discriminated against, these people are biased towards me or my patient for some reason, or when there are complex family dynamics, one person wants one, the other person wants it the other way in the same family. What are the external triggers? External triggers are again healthcare team preferences. Each team, each ICU has its own protocols, has its own way about going about difficult situations. When there is prognostic uncertainty and the environment is not congenial, when there is lot of chaos in the environment, and when either the healthcare team doesn't have proper communication skills or they don't have enough time to use the skills that they have. And this has been found to be the primary driver of ICU conflict. So when there is a combination of internal and external triggers, that is when conflict becomes intractable. It is very, very difficult to overcome or to resolve a conflict like this. Another important thing that we were talking about is bias. So what is this bias? Again, it can be a conscious bias or an unconscious bias. Unconscious bias is something that you don't know that you have that kind of a bias. The person who is communicating or participating doesn't know, or is a part of the conflict, doesn't even know that they have this kind of a bias. But they have those biases. That is an implicit or an unconscious bias. So how do we figure out? There are several tools available on the internet. There's one very interesting tool by the Mayo Clinic where they give you examples, and you can sort of go through a series of questions, and at the end of it they analyze and tell you whether you have a bias on that particular front or no. So we have to make use of tools like that to understand and correct our own unconscious biases. The second one is a conscious bias, where it is very obvious to us. We know that we are being biased towards a particular situation or a particular person, and we are still doing it. So it is explicit. But whatever it is, whether it is implicit or explicit, what is important to remember is it is very, very obvious. It may not be obvious to us when we are stating it, but surrogates, family, patients, the opposite sort of whoever team is, they identify bias very, very easily. So it's very important that we keep bias out of our system as objectively as possible. Another important thing that we all deal with is compassion fatigue. What is compassion fatigue? It's that even well-meaning ICU physicians, after staying in the ICU or working in the ICU for a period of time, they tend to lose their ability to remain compassionate towards family and towards patients. This is especially true when there is a very high volume of patients, turnover is very, very rapid, and you have very, very sick patients in your ICU. Interestingly, the same factors also contribute to burnout. So this is one thing that we have to keep in mind. So now let's understand the cycle of conflict. Now, communication failure, we should understand, is there throughout this entire cycle. It's there at every stage. Basically what happens is there are two parties, two ideas, two sort of interests in a conflict. When these get entrenched, that means both the parties are sticking to their stand and not willing to make any kind of compromise. That is when a conflict begins. So what happens at some stage, there is a lot of moral distress and teams start disengaging from discussion or decision making about care. It completely goes into something else. The discussion, the talk goes into something else, and it loses focus from care, which is our primary aim. So this leads to persistent conflict. So what happens? What if there is conflict for the family? There is a lot of family distress. There could be post-traumatic stress disorders. There could be anxiety. There could be depression. For the healthcare provider, they tend to become very cynical in their approach to that patient or to the next patient. They lose empathy and it can result in burnout. It's very bad. And for society, when they see lot of commotion, lot of conflict, there is a loss of societal trust. So there is a possibility that people, good minded people, stop investing in the ICU and healthcare as is. So it's very important that we address conflict early and appropriately. So how do we address conflict? There are 2-3 methods. One is a consultative assistance, where we call for specialized consultants to come and talk and then help us sort of mediate and address conflict. The second thing you can do is transfer the patient to a different healthcare provider or a healthcare team or a totally different facility completely. You can do that, or you can follow something called bioethics mediation. So coming to principles. Now basically we are talking here about two things. One is mediation and second thing is training. Now unfortunately most of the times we don't have access to trained mediators, especially those that are trained in the healthcare issues, healthcare problems, neutral third party members who can come and sit with us and mediate and resolve a conflict. That is usually very, very difficult. So it's important that we train ourselves. So what should we train ourselves in? We should train ourselves in recognizing conflict, preventing conflict and de-escalating conflict. So before we go to the techniques, this slide is very, very important, because we need to identify that what we see when we look at conflict on the surface is A not agreeing with B for some reason, and that leading to a disturbance in the environment or a conflict. So there could be anger, there could be frustration, there could be sort of henpecking, there could be disorder, there could be a perception of harm, all these that are visible. But when you look underneath, just like in most of the situations, this is only the tip of the iceberg. So when you look deeply, we will all understand that there are a lot of problems. It could be a problem with structure. It could be a problem with values, with policies, with fears that the two parties have, with opposing beliefs, with changing loyalties or habits, or the kind of procedures that are done, or values, or there could be simply a problem with history, with what has happened in a similar situation prior. All these will lead to each party justifying their position and staying there and not being ready to agree to the other person's stand. So what should we do? First thing, we have to start approaching a conflict by understanding two things. One is the position and the second is the interest. What is the position? Position is when we ask somebody, what do you want in a particular situation, the answer that they give. Do you want this to be done? It's like yes or no. It's usually binary, and this is what they articulate externally, what they tell you, what they show you, what they write, that's that kind of a thing. This is called a position. So this is like what is visible outside, it's like the tree. What is the interest? Interest is what leads to this position. It's like the roots of that tree. So these are the actual values that that person has, concerns, and these are why they want that particular thing to be done, to be not done, the way they want it to be done. Now there is a possibility that it may be shared, the interest and the position, but sometimes it may not be. So it's important for us as ICU clinicians to get to the interest rather than stay with the position. Once we understand the interest, then we would know why the behavior is a certain way. Then it takes a lot of time, it takes a lot of patience and commitment on our side to come to a compromise so that we can get away from the conflict. So then de-escalation, again several tools, we have discussed a lot of these before. One is active listening. Second is to demonstrate inquisitiveness when somebody asks you a question or is talking to you. Demonstrate that you are seriously interested in what they are saying. Empathize. Acknowledge again that there could be different perspectives. Name emotions. Abandon moral high ground. Sometimes just saying that you come from a higher moral ground and that you are doing the right thing, no, it may not always be. Even if it is true, sometimes it's good for us to abandon that high ground, come on to the level of the current conversation, the current discussion, and righting wrongs. Whenever something wrong has been done, past or even in the current situation, it's very important for us to correct those wrongs and to acknowledge them so that we can proceed towards conflict resolution. Then of course compromising, it has to happen on both sides, on both parties, right? So this is de-escalation. One very important thing in all this that we should never miss is staff safety. That has to remain top of the priority, and workplace violence mitigation. There should be zero tolerance to workplace violence. Just because we are conducive or we are favoring conflict resolution and conflict management doesn't mean at all that we tolerate violence. No, that's not the idea. Now coming to specific barriers to conflict management in the ICU. One, the time that we have is very, very little. So mediation is very time sensitive. Now you can't sit with the family for hours together and and then keep on telling them the same thing over and over again. Decisions have to be made very quickly, and usually mediation takes a lot of time, number one. Because it's all real-time decision making. Now they have to tell you and then you have to go and do some procedures or go the next step or de-escalate and go that way. Mediators are very hard to find. Most of the times it is you that have to play the role of the communicator and the mediator as well. So that is another big challenge. Third party interventions are, especially if you talk about intra-team conflicts, are usually prone to bias, and usually nobody likes third party interventions, and they usually they spell doom because the information goes out everywhere, it's all out in the hospital that there is a conflict happening. Confidentiality is very difficult and it basically ruins the team. Again, training in mediation is a time taking process, and we don't have too many people who are trained in sort of mediation or conflict resolution in the ICUs. Again, like I told you, intra-team conflicts, always lot of bias is there, so it's very difficult to resolve intra-team conflicts. There are several interesting approaches which are actually for the general population, they are for general work areas or for life in general, but they might work very well. So I think we have to choose, we have to learn a little bit about these techniques and then choose. A few that I found interesting, I just put them. One is the vocab sort of an approach, where V is to start feeling vulnerable, that is to be willing to be seen the way that you are. That would be the beginning. Then to take ownership of your own emotions, needs and choices. To communicate, again two-way, to ask, listen and to express. Then to accept reality and to let go. Let go of things that are beyond your control and accept reality, and to set boundaries for acceptable behavior, and so that there is a mitigation of conflict within that boundary. And once it is beyond that boundary, everybody knows that it is unacceptable. So again, that will also mitigate a lot of conflicts. So this is one tool, the vocab tool. Okay. Now this other tool that I found very interesting, it's by a consultant in conflict resolution, Liz Kislik. Basically she asks us to take 5 steps. The first is to find a dysfunctional person or individual who might be causing the problem. Now, these are usually bullies who are incompetent of understanding that their actions are causing a lot of harm to the team, number one. Second, asking questions. She tells that we should ask questions to people who are actually working on the ground, find out problems so that we get a complete picture of what is going wrong. The third is to align goals and responsibilities to see whether all the team members have similar goals, responsibilities, and to align them. The fourth is, if a change has to be brought in, to find allies for that change at various levels, to find people from each component of the team who can participate in this, in bringing this change. And the last is to inculcate new habits. This is where, our communication will play a big role, like to inculcate empathy, to reduce the perception of fear, pressure among team members, and to be able to speak out uncomfortable truths. So these are things, she gives a 5-step kind of a process for conflict resolution. So I'd like to end today's discussion with this very nice saying that conflict is inevitable, but combat is optional. Thank you for your patient listening.